Welcome. 3 months ago, I've asked the question, what happens to children after they survive cancer? And now I'm glad to tell you that we are really close to the answer. My vision is to improve survival and quality of life in pediatric oncology, and to do that, my mission is to define the long-term socioeconomic side effects of cancer in childhood and researching new therapeutical modalities. I have two main projects going on right now. The first one is concerning social reintegration, and the second one is about the treatment of neuroblastoma. First, I would like to talk a bit more about the comparison of social and economical outcomes between former childhood cancer patients and the general population. Now we are at the stage where 1 out of 800 adults is a survivor of childhood cancer. But when a child has cancer, in a way, the whole family and everyone who loves them has it too. As you can see here, and you will be able to see based on our results, pediatric oncology has a huge impact affecting families, marriages, education, and employment. Based on our knowledge and experiences, we think that former childhood cancer patients have an elevated risk of poor social outcomes compared to the general population. To answer this question, we have conducted a systematic search using the 3 main databases, and during the selection process, we were able to narrow 30,000 articles down to around 300. We are investigating 5 main aspects of life, including education, health risk, and employment outcomes. And I would like to mention here that we are doing supergroup analysis too, based on tumor types and applied therapies. But now I would like to talk a bit more in detail about the romantic and family-related outcomes. First, we have compared survivors of childhood cancer to age, gender, and social status matched control groups. Here, we have investigated the rates of independent living, which is, in other words, leaving the family home and starting their life on their own. Here, and on the coming slides too, the unit of measurement is odds ratio. And when a study population takes place on the left side on the line of null effect, it means that the investigated outcome is present in greater numbers among the members of the control group. So based on that, this plot tells us that survivors of childhood cancer have lower chances to start their independent life compared to their control peers. The reason for that can be the fact that cancer itself and the applied therapies place a heavy psychological and health-related burden on children, which makes them harder to find a job and maintain it, and to start living by their own. After that, we have assessed the question of marriage. Here you can see the rates of marriages among the control populations and the survivors of cancer. I would like to address here briefly the heterogeneity of this plot, especially the last 2 articles. In the first case, the article written by Gerhardt introduced and used a questionnaire at a very young age, at around 18, so there weren't much number of marriages there. And in the last case, the article written by Tebby didn't include in their analysis the survivors of central nervous system tumors, which is unfortunately but historically well-known fact that they are bad at marital rates. And if we follow the traditional timeline, after marriage come children, so then we have assessed parenthood. You can see here that survivors of childhood cancer are significantly less likely to have children of their own. And one of the possible reasons here is shown, which shows that survivors of childhood cancer has an almost 2 times higher chance of facing fertility problems during the course of their lives. Here, the heterogeneity of these articles lies in the fact that different articles use different definitions for fertility problems and infertility. And finally, a nice outcome to tell you about is that although survivors of childhood cancer have a harder time finding their partners and to have children of their own, when they find their partners, they are more likely to find it for the rest of their life, because when we have assessed the divorce rate, we have found a strong tendency that survivors of childhood cancer are less likely to divorce during their lives. I would like to highlight maybe the biggest strength of our study, which lies in its complexity, because we are including all kinds of tumors that affect children, and we are investigating a very broad spectrum of different outcomes which describe the reintegration quite well. Of course, our study has its own limitations. One of it is that the data used by us is based on questionnaires which can introduce reporting bias. So the message of our results and our study is that we can and we should establish in pediatric oncology care a disease-specific, nationally and culturally considered complex and comprehensive protocol for a lifelong follow-up survivorship program. The importance of this task reaches beyond national competencies, therefore this should be performed as a WHO initiative. And the most important thing that we have, if we have this protocol in our hands, is that we must use it. Now we are at the stage of finalizing data tables and statistical analysis, and we plan to finish the manuscript and submit it in July. Now I would like to talk a bit more about my second project, which is about the treatment of neuroblastoma. Neuroblastoma is the most common extracranial solid tumor in children. The success of therapy is determined by the staging and grading of the tumor. As you can see here, the real problem is the very low survival rates of the high-risk cases. In our study, we will compare all available therapies in the treatment of neuroblastoma and compare those in regards of effectiveness, severity, and frequency of side effects. And we believe that there is one existing therapy which is superior in the above-mentioned criteria compared to the other ones. So as I have stated in my mission and vision, we are now on the path of defining long-term socioeconomic effects of childhood cancer, and we are researching new therapeutical ways to improve survival and quality of life. I would like to thank you for your attention with a quote from Dylan Thomas, and it says, "Do not go gentle into that good night. Rage, rage against the dying of the light." Thank you, and if you have any questions, I'm more than happy to answer.
Do you have any data on the suicide rates yet, or are you planning on evaluating them?
The health risk group is not in importance, but in the timeline is the last that we are extracting, so it's under construction right now.
I see. And do you evaluate only for the survivors or for the people who suffer from the cancer and commit before they survive, and compare it to the control group, or only the survivors?
No, only after the treatment and the 5 years survival time after the diagnosis, and then compare it, the articles compare it to the general population. And also they usually take into consideration the post-traumatic stress disorder, which it correlates greatly with the suicidal rates. And I can tell you that based on what I've read and shown here, that there is an increased risk for suicidal thoughts and suicides too.
I just want to ask whether, have you seen any kind of correlation between the publication date and the outcomes? Whether is there a newer kind of treatments maybe have better results in their further life of the patients?
Yes, and in case of the publication year, I wouldn't say that there were significant differences, but I have to mention here that most of the data don't contain, for example, the new targeted therapies, which we will hear later more about, because, you know, when a child, pediatric tumors are the most common in the first decade of their lives. So after that, you need like 10, 20 years that when we can assess these results. One of the greatest and biggest database that we are using and the articles are using called the Childhood Cancer Survivor Study, which is a 25 or 26 institution database in the United States. And those contain data about children between 1970 and 1986, and they are working on that to extend it until 2000.
I would like to ask you about the independent living outcome. I assume that you had age-matched control groups, but at what age can, I mean, I don't know if you can say a number or just around the number, at what age usually cancer survivors leave home, and at what age the control population? I mean, we can see a tendency that people usually leaving home later and later. So can you tell me something about it? Do you see that?
Yes, thank you. Unfortunately, this outcome is not investigated in regards of time. Other ones, such as marriage and, for example, education, employment, there are articles about that. But independent living is usually just a row in a table, and they do not follow up that in time. But I think the results are relevant because they are always age matched. So we can see that.
These outcomes you are investigating are long-term outcomes, and you mentioned that one of the articles collected the data around the age of 18. I would like to ask, what about the others? So how long was the follow-up, or at what point of life they collected these data?
Well, actually, I can tell you that from the ages of 18, usually the criteria is that they are above 18 when the questionnaire is completed. And the upper border is what I found is in the 50s around. So we have data even about those times. So it's kind of a large group of survivors.
My question would be, what was the definition of infertility? And what do you think, what was the reason behind it, the higher risk of infertility? Or could it be the reason for all the other outcomes as well, maybe? Or
well, the articles used categories such as subfertility, diagnosed infertility, and the definition of trying to become pregnant for over a year and not succeeding with that. So these are the three main categories that were used by the articles. And in pediatric oncology, the biggest risk for infertility is the chemotherapy. So we can point that out here. Of course, maybe this can be interconnected, even fertility with marriages, because if you know something about that for yourself, it can affect your romantic life or how you open to people.